internal medicine, neurology at the Lagos State University College of Medicine, and a consultant physician neurologist at the Lagos University Teaching Hospital in Lafayette in Ikeja. I'm excited to collaborate with WASI, the West African Stroke Initiative, to introduce and expand endovascular neurointervention and stroke care in Nigeria. Well, we have several stakeholders from various parts of the world joining us today, including neurosurgeons, radiologists, neurologists, the pathologists, the nurses, technologists, and hospital administrators. We usually put together these ground rounds on a bi-monthly basis. The title of today's ground round is very unique. It relates to venous sinus thrombosis and current treatment considerations. Before I introduce our moderator and presenter for today, I would like to do a few housekeeping announcements. Please kindly observe this. One, mute your microphone unless called upon by the moderator or presenter. When sharing your screen or video, be mindful of what is in your background. And I will also expect there may be a few technological hiccups. Kindly, we'll have the opportunity to answer questions. After Sean, please type it into the chat box. The moderator will read your question to the presenter during the question and answer session. Additionally, if you would like to ask your question directly, use the raise hand feature in Zoom, and you'll be invited to ask your question during the Q&A. I will ensure that your hand doesn't start pinning you, so you won't keep that hanging for long. Well, our moderator for today, of course, is Dr. Uchenna Okafor, a very well-renowned assistant professor of neurosurgery at the New York Medical College in the School of Medicine. He's also the CEO and the co-founder of the West African Stroke Initiative. He's also an attending neurosurgeon, vascular neurointerventionist at Westchester Medical Center in New York. Well, our presenter today is Dr. Violiza Inoa, MD. Dr. Violiza Inoa is a vascular neurologist and neurointerventionist. She's part of the neuroendovascular professor, the Department of Neurology and Neurosurgery at the University of Tennessee in Memphis, as well as medical director of the Baptist Memorial Healthcare.
Tuko, I think we lost your audio. Are you still there?
Prof, maybe if you turn off your video, that might help with the connectivity.
I'll reach out.
Just give us a second to try and get him back. And
she's the program chief, National WSO NIR Fellowship. Dr. Inoa, I think the floor is yours.
Thank you so much. Can you guys hear me and see me well?
we can.
Perfect,
Yeah,
perfect. And you can also see my screen, correct?
You want to maximize the screen, maybe? Okay, good.
Okay.
Yeah,
That looks
that's good.
okay.
Looks
Perfect,
beautiful.
perfect.
Thank you.
Yeah,
Well,
your screen.
thank you so much. It is a true honor to be here among all of you. I was reminded the other day by Dr. Okafor that we met a couple of years ago, and it was so not just interesting, but very inspiring to see all of the work that you have been doing over the past few years. So I really congratulate all of you. And I am honored to be here. And thank you for I really thank you for the kind invitation and for the introduction. So as we expected, we are going to be talking about venous sinus thrombosis today. I have some financial relationships that truly would not affect the content or the recommendations of this talk. And I wanted to start with few cases. Interestingly, although this is not a very common disease, we had 3 cases in our service this past week, and some of them I actually wanted to include here because, as you know, the patients won't show up with a diagnosis written on the forehead. So you really have to think about your cases and how to get through all of this. So this patient is 52, female with known history of hypertension and migraines. And she comes in, believes she was driving and she became acutely confused. The family noted that she could not talk and she had aphasia. She came in with a GCS of over 14 and aphasia. And as you can see here, she has this left temporal intraparenchymal hematoma. So obviously with history of high blood pressure, you think about that a potential etiology, although with a lower bleed, you think that this might not be a typical presentation. As part of our workup, we do an MRI with and without contrast. And interestingly, you can see here that there is this hyper intense finding within the left transverse sinus. And when you look at the other sequences, post contrast, etc., it just makes sense. We are talking about potential venous sinus thrombosis here. So the next step would be to investigate the venous sinuses either with an MRV or a CTV, and we'll talk about which one and when we do one of those sequences. And on the CTA, you can see here, by the way, without the CTV sequences, the delayed CTA sequences already show you that you have a thrombus within the transverse sigmoid junction with this filling defect here. And again, you make the diagnosis. Now, it's important when we look at the pictures to compare to the other sinus, especially if it's not a contralateral hypoplastic sinus. It is really useful. And when you look at the other sinus is patent open, you look at this finding and you truly feel comfortable with this diagnosis. Now, what would be the management of this patient who comes in with a sizable intraparenchymal hematoma that already has some midline shift? And the treatment is anticoagulation. Again, we'll talk about a little bit the data behind anticoagulation and why we use it, but that's what we started. So essentially, IV heparin acutely transitioned to oral anticoagulation, and you monitor this patient. And at 3 months on anticoagulation, the patient, I saw her in clinic, repeated some imaging, and she remains with residual aphasia. But you can see here how there is already some reconstitution of the transverse venous sinus. Looking back at this case, she was diagnosed with breast carcinoma 1.5 years after we made this diagnosis. So again, trying to look into the etiology and why these people come in with this pathology is also very important. Another case, this lady is 21, and she comes in with headaches and double vision. She has family history of a hypercoagulable disorder, unknown, and she comes in after she had COVID. So on the exam, she has a mild 6 palsy. She's COVID negative at this point. And on the CT, without contrast, not a lot if you do not know what you're looking for, but please look here at the posterior portion of the superior sagittal sinus, and let's compare to this MRI. We got this MRI, evidently you see this hyper intense signal within the right sigmoid sinus. And when you look at this MRI, let me stop here. Hopefully this is going to work. See this abnormal finding, also the abnormal signal. Perfect. So this abnormal signal here on the right that actually is comparable to what you see on CT. So this woman was diagnosed with extensive venous sinus thrombosis, and she was started on anticoagulation. This is her MRV. Before we started anticoagulation, usually we again do a venous sequence, either MRV or CT venogram, discharged on anticoagulation, completely asymptomatic, but she comes back weeks after, sent by the ophthalmologist because she has worsening papilledema on exam. She has more headaches and she has a sixth palsy. So again, what to do now? You're already anticoagulating her. She is therapeutic. She's taking her medications. So again, what next? We repeated the CT. In this case, it's a CTA. It's a delayed sequence CTA, which although does not have the reconstructions of the CTV, ideally you do the CTV, but we can see pretty well the venous sinuses. And you can see that the superior sagittal sinus looks way better and it has reconstituted significantly, although she still has some clot here within the right sigmoid sinus, again, compared to the other side. So at this point, we decided to bridge her and perform a therapeutic lumbar puncture. Her opening pressure was quite high because we thought she was suffering from increased intracranial pressures. We did a large volume tap, removed a lot of fluid, had a normal close-in pressure, continued anticoagulation, and put her on Diamog. So we treated her as if she was having IIH in a way, although this is not the underlying pathology. And she did pretty good. She's still following up with us and she continues on anticoagulation because she has a hypercoagulable disorder. Another case, which was, I think, atypical and challenging, and I wanted to show today, she's 51. She comes in with altered mental status and facial swelling to the ER. EMS was called and they thought she was having an allergic reaction, so they gave her some epi and Benadryl. She has history of HIV on heart. She's not immunocompromised, but she also has history of kidney failure, CHF, liver congestion. Like she is a lady with a lot of comorbidities. Now, EMS brings her to the ER, but this went south pretty quickly. So this woman, they noted that developed proptosis, periorbital edema, chemosis. She lost her airways, could not move her eyes. She had ophthalmoplegia, and her eyes were tinged with bloody drainage, which is something that I honestly had not heard or seen before, not in outside of the setting of trauma. And they got a non-contrast head CT, and you see, at that point, you're not sure what you're looking at. Looking back, obviously, subdural hematomas, but is this thrombus? Like, what is really going on? Evidently, there's, this hyper dense signal within the superior sagittal and straight sinus. But retrospectively, I think it is all subdural hematoma. But interestingly, when you look at this, there's definitely extensive clot within the right jugular vein. And I want you to think about this, right? So you can see the thrombus here. I have other still pictures here that show the same. And you have extensive thrombosis within the right jugular vein. However, when you look at the other side, the left jugular vein is normal. It's draining. So what are you thinking? Or like, what are the thoughts? It does not make sense that one is draining, the other one is not. And still you have this clinical picture. This woman coded at the other hospital. She was trached emergently. She was flown to us for thrombectomy. And at this point, I just decided to go ahead and do a diagnostic angiogram, see what was going on. And I found something that I had not seen in this setting. So this woman had such high intracranial pressures from a venous etiology that the venous sinuses were not even feeling when we did a diagnostic angiogram. So there was really no blood flow getting into the venous system at all, which correlated with the clinical picture. So we went into the venous system and we got an angiogram again to understand what was going on. And we got into the right IJ. We did thrombectomy, and then evidently this was the problem, which makes sense. So she has an SVC syndrome, which is pretty lethal and very dangerous if you do not identify it and treat it. We did a lot of heroic measures with this woman that was clinically almost devastated. We got a dynasty T on the table, and she had expansion of her subdural hematomas, now with bilateral subdural hematomas. And unfortunately, she did not well and she passed. So let's talk a little bit about the incidence of cerebral venous sinus thrombosis. As I said, it's not really common, but it's a diagnosis that you have to keep in the back of your mind because you're going to see it. And if left untreated, the mortality can go up to 30%. The independent risk factors for mortality are patients who present with deep venous system thrombosis, patients that present with intracerebral hemorrhages, again, low GCS, altered mental status, and male gender. Much of the natural history of this condition is really not new. It comes from the international study of cerebral venous and dural sinus thrombosis. And it is a condition that affects younger people with some predisposing risk factors, people and females that take hormonal contraceptives are higher up in terms of the risk. People with hypercoagulable conditions, pregnant women, especially towards the third trimester and the postpartum phase. And we've seen it also with patients who come in with local infections, meningitis, mastoiditis, etc., and other conditions. Now, there are other causes that are less common, and the point is not to go over each individual cause, but I really want to point out that if you don't have an obvious cause, it's worth, as you monitor and follow these patients, to look into some other etiologies, because as I said before, one of the patients that I presented at the beginning of the talk was ultimately diagnosed with breast cancer. And I'm pretty sure that if someone would have screened at the beginning when she presented and not just assumed that it was dehydration or other etiology, probably the outcome of this patient would have been better. Another way of looking at potential etiologies is just to go back to the basic of medicine and why the thrombus happens, the virtuous triad, right? So it's either because of hypercoagulability states, altered blood flow, which can be even extrinsic compressions, endothelial injury from inflammation, from infections, etc. And the thrombosis can affect any venous structure in the brain. And as you know, the venous anatomy can be quite variable. The most common structure affected is the transverse sinus, followed by the superior sagittal sinus, and occasionally we also see the straight sinus. Now, the venous system, the deep venous system can be affected in about 15-16%, but think about this, as you occlude the drainage of the the deep cerebral structures, these patients are going to present with altered mental status, lower GCS, and this is probably one of the most devastating presentations of sinus thrombosis. More likely, it's going to be the straight sinus. We had a patient the other day that had a vein of Galen and intracerebral vein thrombosis. Again, you have to think about all the sinus structures, but also the cortical veins, which can be affected in 17% of the cases. These are usually more difficult to diagnose, and sometimes, it requires more advanced imaging and diagnostic angiography. When the clinical picture points at venous thrombosis and you do not find anything obvious, again, sometimes it's indirect finding. It's an indirect finding on an angiogram, which is going to point to the diagnosis. But I always look at the jugular veins, specifically on patients that have some underlying thrombosis for some reason, or hypoplastic sinuses on one side. If they were to occlude a thrombose, the contralateral side that was patent, the venous outflow is obviously compromised, and we have to think about it. The manifestations clinically are more likely related to increased intracranial pressures because of the decreased venous drainage, and most patients will present with headaches. Like I mentioned before, our patient presented with a headache, papilledema, and diplopia, which can happen. And of course, focal symptoms, seizures are going to be present if you have an ischemic infarct and hemorrhagic conversions. A typical presentation, but can happen, is psychosis. And this is insidious because unless you have an abrupt occlusion of a sinus, this is going to happen over time. So the patient is going to tell you that they started having symptoms days and even weeks before, and it kind of progresses over time. ICH will occur in about 30 to 40% of the patients. Now, the diagnosis is obviously with neuroimaging. And once you know what you're looking for and you add it to the clinical picture, it's really not a super challenging diagnosis to make. The first step is often, or what you have available is often a plain CT with no contrast. You're going to find abnormalities within the CT in about 30% of the cases. And the abnormality on plain CT is going to be this. As I showed before, you're going to see a hyperdensity within a dural sinus. Occasionally, you see a hyperdensity within a cortical vein, but it's not quite often that you see that. And there's this so-called classic empty delta sign. That is when patients have a thrombus specifically within the superior sagittal sinus, specifically the here at the junction with the torcula, they have the thrombus, and when you do a CT with contrast, you can see this. Now, another interesting finding, when you see a patient who comes in, a CAT scan shows that they have a stroke, occasionally with some heme conversion that does not respect the vascular boundaries, you please suspect of venous sinus thrombosis. On the MRI, we see absence of flow voids and abnormal signal intensities, and the hallmark would be an hyper intense vein sign like we can see here. So this is the junction of the transverse and the jugular sinuses here, and you can see again this hyper intense sign. Look at the other side. This looks abnormal, and the T1, T2 MRI sequences are quite helpful. And I often come back to this table because it actually ages the thrombus because of the degradation of the hemoglobin. So usually in the acute phase, we see ISO intensity 1 with hypo intensity 2 sequences. And after a week or so, this is what we see the most. Remember that I was explaining that these patients come in with a very insidious presentation in the subacute or even chronic phase sometimes. So you're going to see the hyper on T1, T2. With the MRI with contrast, you're going to see that central isodense or lesion with the surrounding enhancement that I was showing you with the first case, I believe. So again, a very kind of iso, sometimes hypodense with surrounding enhancement. Now, CTV and MRV are going to be recommended every time you suspect venous sinus thrombosis. If you look into the literature, they're pretty similar in terms of the diagnostic accuracy, their sensitivity, their specificity. Now, locally, I asked my neuroradiologist, and they don't like MRVs. I think some of the pitfalls of the MRVs is that they're not readily available everywhere. They're very sensitive to motion artifact. And also, if you have slow feeling of a sinus, it can be, for example, like a hypoplastic sinus, it can be confused with thrombosis, which is inaccurate. So some of the findings on CTV, you can see here, again, compared to the other sinuses, sometimes it is quite obvious that you have extensive thrombosis like this patient within the transverse sinus and torcula. And by the way, the majority of these cases, I think this CT is not one of our cases, but the majority of our cases are real cases. I'm not I'm not cherry picking online to look at beautiful pictures. These are cases that we see in our practice. So these are the images that you're going to see if you do the right sequences and the right studies. This is classic for a CAT scan of a patient that has deep venous sinus thrombosis, specifically the straight sinus. So you're going to see that hypodense areas within the thalami and sometimes the caudate nuclei, and this is worrisome. So this is a patient that you admit to the ICU regardless. And sometimes they come in comatose, not looking great on exam. But this patient that I had this past week, 21 on oral contraceptives, she came in with delusions. She was lethargic initially, but by the time we saw her, she had a GCS of 15, which was incredible because she did have thalamic hyperemia, right? She has, please look at this hyperintense sign that is highly suspicious for venous sinus thrombosis. And certainly here on the MRV, you can see that there's thrombosis of the Galen and the straight venous sinus. So this patient is a patient that has a very worrisome presentation. She's likely to get worse if she's not treated aggressively. And I guess the question is, what does aggressive treatment mean? And because of the time constraints of this talk, I really want to continue, and maybe we can go back to this conversation if we had more time and as we have questions towards the end. Now, few findings for you to remember. So this is a patient who came in with prior TBI, and he came in with intractable headache and vomiting. So just a plain CT can give you the diagnosis. So look at this. You do a CT of the head without contrast, and you're going to see the high intensity here or high density of the sinuses. You confirm that with an MRI. You start with an MRI, you do an MRV, and you can see it right here. So it correlates. So ISO on the flare and T1 post contrast is ISO again, ISO or hypo again, and again, you got the diagnosis. And I think this is hyperacute, or excuse me, or acute based on the MRI findings. This patient was started on anticoagulation, and I really want you to see how remarkable the improvement of the sinus reconstitution was on this patient. So 6 months. I usually repeat, depending on the patient, an MRI, MRV, 3 months, and continue to follow and repeat again in 6 months. But at 6 months, there was essentially almost complete reconstitution of the superior sagittal sinus here. Look at the extensive thrombosis of this patient and how well they did on anticoagulation. Another patient, again, similar findings. Patient had recurrent GVM, unfortunately, and he presented with headache, altered mental status, and vomiting. Please pay attention to the sinuses when people present with clinically some symptoms that could be related to increased intracranial pressure. Even again, these are the patients that come in with meningitis and brain tumors and other even potential causes. But these are also the patients that will have an increased risk of venous sinus thrombosis. When do we do a DSA? When do we do an angiogram on these patients? And these are reserved for patients in which the regular technique, the regular diagnostic pathways with CT, CTV, MRV, MRI are inconclusive. It can happen, especially when we have smaller sinuses, or when people come in. To be honest with you, I'm going to showcase people come in with bleeding or findings on MRI, and they do not why the patients, the etiology of those bleedings, and we do an angiogram and we're like, oh, yeah, venous sinus thrombosis. We also do DSA when endovascular treatment is being considered, and I'll talk a little bit about the data, and rarely for venous pressure measurement. On the DSA, we often see the failure of the sinuses, so the sinuses are not filling, but also there are indirect findings that we can see. So venous sinus congestion, sometimes we see just retrograde venous filling, so the reversal of the venous outflow, and venous enlargement. The venous enlargement, it's very it's very hard, right? Because there's so much variation within the venous anatomy. But again, you have to add up, all of your findings with the clinical presentation. And I'm going to show you some of the cases so you understand how these patients can be diagnosed on angiogram. This patient already had the diagnosis, but he had extensive venous sinus thrombosis and infarct despite anticoagulation, and this patient was taken for thrombectomy. And what you see here is that there is lack of feeling of the or opacification of the superior sagittal sinus and the right transverse and sigmoid sinuses, as you can see here. This is an interesting case because, again, this patient comes in with a left temporal hematoma, 48. He has history of hypertension, and they do not take the blood pressure medication. So, again, is this blood pressure related? What is happening? However, it's atypical. The patient is only 48, and they requested an angiogram to see if there was an arteriovenous malformation or something different. But what we saw was quite interesting. So essentially, you start seeing like clot within the vein of Lavey, and then you try to trace it or find it, and it's absent. So this patient had an occlusion of the vein of Lavey, and that was the etiology of the bleeding. So what do you do for this patient? And then the evidence shows that you put this patient acutely on anticoagulation, followed by anticoagulation orally afterwards. This is one of my patients. This is from a few months back. She came in with high convexity subarachnoid hemorrhage. Again, nothing that we could see on non-invasive imaging. What is the etiology of this? And when we got the angiogram, we had the aha moment. So this was really not evident on the on non-invasive. And you can see that anterior portion of the superior sagittal sinus is not opacifying there. But there's also something interesting, which is, by the way, the first thing that I saw. And that is that the superior ophthalmic vein, it has retrograde feeling. And I was like, okay, that's interesting. And then, we saw and we diagnosed the superior sagittal sinus thrombosis. And again, we started this patient on anticoagulation. Other diagnostic modalities do not have, significant value, in my opinion. I'm not familiar with some of them, but I think the majority of your patients are going to be accurately diagnosed with, if you follow the sequence that we talked about. Remember, though, that the venous anatomy can be variable. Some people have hypoplastic sinuses, so please take that under consideration. Again, look back at the clinical presentation and make sure that things make sense. Remember that the arachnoid granulations are in the differential, especially when you're thinking about like a local feeling defect or intrasinus septa, etc. So think about other things as well. When do we recommend imaging? So as I said before, if you have a lower ICH of unclear etiology, or even like an infarct that does not respect any vascular distribution, get a CTV, MRV. Patients with idiopathic intracranial hypertension, we are more often getting venous imaging. People with headaches, especially younger females who come in with headaches with atypical features, especially if those features are related to possible increased intracranial pressures. And as I said before, bilateral thalamic lesions, get those imaging, and the modalities are the ones that we discussed before. We follow up, as I said, at 3 or 6 months to assess the recanalization of the sinuses after therapy. Let's stop here and let's talk about treatment and therapy. The gold standard treatment for patients who come in acutely with venous sinus thrombosis is anticoagulation. And we start with anticoagulation or low molecular weight heparin because obviously it's reversible. Some of these patients come in with ICH, etc. And that is the data that we have for unstable patients. And that anticoagulation is going to do 3 things. So it's going to prevent thrombus propagation, facilitates the recanalization of the sinuses, but also in patients that are already with hypercoagulable conditions, they prevent other clots from happening, PEs and DVTs, etc. And although we wished that we had robust data, with thousands of patients for this condition to prove that this is the real deal, let me tell you, we do not. When you look back, the best paper that we had was from the 90s, and they only treated 20 patients. It was published in the Lancet. And besides their 20 patients, they also looked retrospectively at about 100 patients, 102 patients, and they analyzed these patients. And the 20 patients they randomized at 3 months, 8 patients had complete recovery when they were treated with anticoagulation acutely versus only 1 patient in the placebo group. And then out of the patients that were not treated with anticoagulation, 6 of them had disability from neurological conditions. 3 died and 1 had a PE. So out of these patients, they strongly recommended that we treat these patients with acute anticoagulation. And same thing for the patients that they analyzed retrospectively, they found that the mortality with heparin was only 50, not only, it was It was significant at 15%, but it was definitely lower than 69% of the patients who died when they were not treated with anticoagulation. And there's something else. The patient should be bolused and therapeutic on anticoagulation. It's not a soft anticoagulation, low PTT type of deal. These patients need aggressive treatment. There's another randomized trial that included 60 patients. And what's interesting about the trial is that the patients that were treated with heparin did not develop symptomatic cerebral hemorrhage. On a meta-analysis, the difference between the patients that were treated with heparin versus those were not treated with heparin was 13% favoring anticoagulation in terms of death or a neurological disability. If we look at all of the observational studies, or most of them, that treated people with cerebral venous thrombosis with anticoagulation, what we see is that the risk of ICH, regardless of these patients coming in with an ICH, remember, up to 30% of these patients will come with ICH. The risk of ICH, either new or expansion of the ICH, is fairly low. New ICH is about 0 to 6%, which is in a way accepted as if we do not treat these patients, the mortality is going to be quite high. So the treatment phase is as follows. We treat these patients with IV heparin or low molecular weight heparin, which, by the way, is favored nowadays, in therapeutic dose acutely. Now, we monitor the patient clinically. If the patient is clinically stable, we transition those patients to a maintenance therapy, which is anticoagulation. Before it was Coumadin. Now we are using the direct inhibitors, the DOACs, which have been demonstrated to be equivalent or non-inferior to Coumadin. And we keep those patients on anticoagulation for at least 3 months. Now, depending on the etiology of the sinus thrombosis, so for example, if it's a provoked thing, patients were infected, dehydrated, well, so we transition them to, we stop anticoagulation. You can transition them to aspirin, whatever you prefer of anticoagulation. However, for people that have known risk factors, hypercoagulable disorders, ongoing issues that will increase the risk of further thrombosis, you keep them on anticoagulation. And I've kept these people sometimes on anticoagulation lifelong. Again, if you were to compare DOACs to vitamin K antagonists, they are non-inferior. There are 2 randomized clinical trials that actually show a trend of less bleeding with DOAC, and I'm talking about after the acute phase. In the pediatric population, there was one trial called Destine Jr., and they tried rivaroxaban, and they proved that it's non-inferior to a standard therapy. Of note, remember that the DOACs and the VKA will cross the placenta. So for pregnant women, we recommend the heparinoids or until they are 6 weeks after they deliver the baby. There are some exceptions. For patients that have antiphospholipid syndrome, we recommend the warfarin, the vitamin K antagonist, because that is the therapy that has been proven to be efficient. What about recanalization? With therapy, we have demonstrated that there's going to be recanalization in up to 85% of the patients after they are treated in 3 to 6 months when you recheck with a CTV or an MRV. Other treatment interventions are offered when patients do not respond to adequate anticoagulation. Either they get worse clinically or there's contraindication for anticoagulation. Of note, ICH, intracranial hemorrhage, is not a contraindication for anticoagulation, as we discussed. Patients that have intractable high intracranial pressures are also offered other therapies like thrombectomy and decompression, and we're going to briefly cover those in the data behind them. Direct catheter thrombolysis has not been established as an effective therapy. There are some non-randomized clinical data showing urokinase years ago now. And again, we do not recommend it. When we tried mechanical thrombectomy with or without urokinase or direct thrombolytics, we demonstrated that mechanical thrombectomy might be favorable on some of these patients with an increased recanalization, and there was an increased, I believe, a mortality rate when we added the thrombolytic. So usually we do not do mechanical thrombectomy with thrombolytic, and we reserved mechanical thrombectomy again to some cases. But let me tell you, there is only one randomized clinical trial looking at mechanical thrombectomy or venous thrombectomy, and the trial was halted after their first analysis because it failed to demonstrate that thrombectomy is superior to medical management with anticoagulation. This was an open label study, multi-center, international. And they included patients that came in with very poor exam, comatose, and that had ICH, people that had deep venous disease. Obviously, these are very sick patients, so the mortality is pretty high. However, for this specific population, there was no benefit of the mechanical thrombectomy. And the technique is going to be variable depending. We use different things. We do aspiration thrombectomy. The bigger the catheter, we do a lot of heparin. So watch out, because sometimes these patients lose a lot of blood during these procedures. We use stent retrievers. We use the Doherty balloons. We use a lot of different things. There's the angiojet irrigation system that I believe is used for peripheral. I haven't used it particularly, but again, the goal is to open a channel to improve venous outflow. So in my practice, what we do is we get a diagnostic angiogram, arterial sheath, 4 or 5 French. We diagnose the problem, and we take all of our roadmaps from the arterial phases, and then or the arterial side, venous phases, and then we go intravenous femoral, for the most part with a 6 French or 7 French sheath. However, if you are going to go direct venous jugular, please remember that some of these patients have contralateral clot or have contralateral disease. So be careful, because you can always have problems or complications that could affect even further the venous drainage. This is a patient that underwent mechanical thrombectomy to the venous system, superior sagittal sinus, by one of my colleagues. He does most of our pediatrics. And Dr. Elihovich was presented with this patient who's 7 with a B cell ALL. The patient got worse despite adequate anticoagulation with IV. And then he took him for an angiogram, and you can see how there's this venous filling defect in the superior sagittal sinus, and which was quite extensive. So you can see the catheters here. I hope you can see through this screen. And you can see how there is an aspiration catheter all the way up here. So this is pre and post. So this is a very good result, and this is essentially what you want. You want to see revascularization in a venous channel to open up for these patients. This kiddo was discharged on stable conditions, mild left-sided weakness, because he did have a right frontal hematoma. Endovascular procedures are often considered nowadays for patients that have ongoing sequela of venous sinus thrombosis with venous stenosis. So we look at those patients, we continue anticoagulation, we treat them with diamox and diuretics. They do not get better, they continue to have symptoms. And if they failed medical management, you can consider endovascular venous sinus stenting, specifically if there's a venous lesion. So we've done that, and this is has been published. So that's also something to consider. And just to touch on the final points, the surgical management includes either open thrombectomy. There are some case reports, but that's really not recommended, and decompressive craniectomy in some of the patients that come in with malignant cerebral venous sinus thrombosis, which is about 4% or so. So if you look at case series, the largest comes from Faro, and 15 or 16% of those patients died despite decompression, and about 6% were severely dependent. Now, although there's low level of evidence, surgery and decompression should be performed and is recommended by societies, etc., for patients that have impending herniation. So obviously the mortality is out there and it's high, but you have to have that conversation with the family. Remember, the majority of them are going to be younger people, younger patients, and younger females. And this is also coming from the European Stroke Organization guideline and for diagnosis and treatment. So again, surgery saves lives, and the level of evidence is not great, but it is recommended. The quality of evidence is not as strong, but the recommendation is strong. If you want to talk to your patients about quality of life and outcome after surgery, we have data from 2 systematic reviews and some non-randomized case studies. Death is about 19%, but 31% of the patients achieve complete recovery. Okay, so going back to general treatment principles, besides the basics, the main treatment is acute anticoagulation with IV heparin or low molecular weight heparin. For refractory CVT, salvage endovascular therapy, but this is not supported by randomized clinical data. For patients that have intractable ICP, the compression is considered, but often recommended. However, the evidence is not as strong. So again, I'll stop here. I think maybe a couple of minutes within time. So I'll take any questions, and I again appreciate your attention and thank you so much for this opportunity.
Dr. Ogo, are you there? Okay. Professor Ogo, back.
Carry on, sir.
Okay. Dr. Inoa, this was, as usual, a perfectly delivered presentation. Thank you very much. I went through the topic before you presented, and you covered above and beyond. And we are very, very grateful for the excellent presentation this morning or afternoon. Well, Professor Ogo is back. Please go ahead.
Well, just to appreciate her, for that very brilliant delivery. I think it's been very, very well presented and very quite clear. But I think the floor is now open for questions and comments. Dr. Okafor, the floor is yours now. Thank you.
Okay, so we have a few minutes. We still have Dr. Inoa with us. So I wonder if anybody has any questions. You can put it in the chat. You can unmute and ask the question. Please feel free. We're getting the best of the best. So let's take the advantage.
You're very kind. I while people think about their questions, I want to go back to the case that I presented. This 21-year-old, this was maybe no more than 2 weeks ago now, and she came in with the thalamic lesions, hyperemia, and deep venous sinus thrombosis. And I thought that that patient was going south. I didn't think she was going to do well just based on the imaging. But I kept looking at her, a little bit somnolent sometimes, but overall doing okay. I had the discussion with the family and I said, we do not have strong data. However, we can consider the thrombectomy. We can always consider that. However, we can always make her worse. She could have complications from a procedure when we know that this is not the procedure that we should be offering upfront because of the level of evidence that we have. And we decided to aggressively anticoagulate her, and she did fine, to my surprise. To be like, I didn't understand how she was still awake. So, just going back to this, right? Sometimes we think about it and we really want to be extremely aggressive, and we think that we have the best answer. However, the evidence shows for this particular disease that if you're able to adequately anticoagulate these patients and they're clinically stable, you can monitor them. If they get worse, then that's the time when you act.
Okay. Did you end up doing the mechanical thrombectomy for her? For this?
No, she didn't needed it.
She did well with the anticoagulation.
Yeah.
That's awesome. Okay, we have some questions rolling in, so let's get to it. We have one of our neurosurgeons, I think from Jos, Dr. Yang. He says, what is the place of anticoagulation in post-traumatic venous thrombosis?
Mm-hmm. That's a very good question. Again, if I've done a few things. So if we're dealing with polytrauma and the patient has extensive or clear contraindications for anticoagulation, and the patient is really not symptomatic for venous thrombosis, we just monitor.
Okay.
However, again, if this is kind of incidental, I look a lot at the MRIs to try to age the venous thrombosis and look at the patient's symptoms, right? And we monitor, but that patient probably would have lower risk of bleeding in the setting of anticoagulation. So for trauma, I do not always anticoagulate.
All right, thank you very much. I hope that was clear, Dr. Yang. I know for cases that where we have fractures across the skull, cuts across the sagittal sinus, that's usually a case where they get thrombosis. But the risk sometimes outweighs the benefit here for trauma. Okay, so the next one comes. It says, thank you for the presentation. Is there any scoring system? This is from Chinoye Ezewabuchi. I hope I didn't make a mess of the name. I apologize. So John, he says, is there any scoring system that would be used to assess the possibility of ICH when considering anticoagulation in CVST?
There's none that I know of. There's none. I mean, from a personal experience, if you have more extensive venous thrombosis, the patients are going to present it, especially because the majority of these patients have extensive thrombosis within the transverse sinus. So sometimes they present with that temporal hematoma. But it's very interesting too, because occasionally you have people with bleedings and all they have is a cortical vein that is occluded. So there's a lot of variation, and sometimes I really do not understand, right? But it really depends on the patient's anatomy and their capacity to compensate that venous drainage that has been lost. There's no grading system that I know of. Sometimes people get very nervous when there's ICH, but we always anticoagulate.
So just on that note, just for the audience, why would you, for somebody who is just like, what is going on? Why would
Yeah,
you anticoagulate when there's bleeding? There's a
correct.
venous hemorrhage, and we're anticoagulating. Some people say this is crazy. So would you
Yeah,
walk us through, just for those who are wondering, why
absolutely,
does this work?
absolutely. So what happens is that the underlying pathology is lack of venous drainage, extension of the clot, and then the more progressive, the more bleeding that you're going to have, the more infarct that you're going to have, and poorer outcome. So what happens is that once you anticoagulate, what you're doing is you're trying to create channels and you stop the propagation of the venous, the thrombus, and then the venous drainage improves, and that's what we think happens, and that's what helps the patient. So it is different from other bleeding pathologies in ICH, right? Because again that those patients are less likely to do better if you anticoagulate, but this is very different. The pathophysiology of the disease is very different and is treated with anticoagulation.
Thank you very much for explaining that. We have another question from Christopher Wanachi. Says, okay, thank you for the beautiful presentation. Says, what common complications could be commonly encountered following a mechanical thrombectomy, a venous mechanical thrombectomy?
So there's always, like any other procedure, access complications. Access can be difficult because of the variation of venous anatomy. You have to be careful with perforation. So we try to kind of J wires and make sure that we are pretty careful with that. What I've seen too is that these patients, so you are giving a lot of heparin during those procedures. As I said, they can lose a lot of volume. So you have to be very cautious with that. I guess technically you can always, like, you can fail. We've had those patients too. We do the procedures and we do not get anything open. And tech technically, I guess you can make things worse. Let's say with catheters, etc., expansion of the clot, or maybe getting clots where, in venous structures that didn't have clot before. I haven't seen that, but I guess those are like the technically that can happen.
Thank you very much. I was going to ask,
Oh, I
okay,
do
go
have,
ahead,
I
please.
have to say something though. Um, on the randomized clinical trial, I think they had few complications. One of them was a fatal epidural, and another patient had bleeding as well. And I do not remember the third. Oh, I don't remember the third, but just those were the complications from the clinical trial.
Okay, not without risk, but might just be the last chance or the last opportunity the patient has to survive. All right, so with regards to pregnancy, since we know that's a risk factor, is a history of cerebral venous sinus thrombosis a contraindication to future pregnancy? What would you say to an expectant mother?
No, no. And actually, there are some guidelines about it. And the likelihood of it happening again is fairly low. However, the results are biased because, of course, these people were prophylactically treated. So, so they can get pregnant, but usually they are anticoagulated throughout. I'm not sure if throughout or if it's towards the end of pregnancy.
Thank you very much. So that's a relief.
Yeah.
Okay, so we have another question. This is generating a lot of interest. How do you easily distinguish a cortical venous thrombosis with cortical involvement from irregular arterial hemorrhage? So how do you differentiate, I presume, arterial versus venous?
Oh, okay.
That's not what I get from this question. This is Dr.
Yeah,
Ealing again.
I get it. I get it. So cortical venous thrombosis is really not an easy diagnosis to make. So you have to in my opinion, you have to suspect it. So the patient, of course. And again, we're talking about like a younger population. So if someone comes in with that clinical picture and they're 75, you're going to think about cerebral amyloid angiopathy, for example, right? But if you have a younger patient that has the risk factors, or, you know, one of the pathologies that I presented before, or genetic predisposition, family history, etc., that location, you look very carefully at the CT, the CTV, and the MRI with and without contrast. Sometimes what we see is like on the T2 sequence of the MRI, you can see that cortical vein. But for those patients, I have a lower threshold to do an angiogram. And sometimes on an angiogram, I do not necessarily identify that the vein is missing. However, you can see indirect findings, either, as I said, like venous hyperemia sometimes, or retrograde venous outflow. And that's how you kind of make the diagnosis. But it's a tricky thing. You just have to think about it.
Great, thank you very much. I'm wondering if anybody else has any, we're almost time up. We need to wrap up, but if anybody else has, I'm sure there's, Dr. Anna, there's been almost 100 people on the line. It's been a fantastic presentation. You went to town, and I think this will be a very good resource. This presentation will be posted on the WASI website, so feel free to go back to it, study it. You can play it for your residents, for those who are attending, for those who are residents on the line, and of course for our faculty as well. So I don't know if there's any senior faculty that will want to make a mention of your own personal experience in Nigeria, or if you're dialing in from any part of West Africa. Please feel free to share with us before I pass it back on to Dr. Ogo, Professor Ogo. Okay. Okay. All right. So thank you very much. So I'll pass it on to Professor Ogo. Back to you, sir.
Dr. For Dr. Kuyoro is here.
Oh, okay. Dr. Barra wanted to say something. Okay, Dr. Barra, please. He's one of our neurosurgeons in the East, in Imo State. Please go ahead, Dr. Barra.
Okay. Thank you, everyone. Thank you for the great presentation. We learned a lot. I'm sure. Can you hear me?
Yes, we can. Dr. Barra, yes, we can.
I'm sure we're still going to be keeping in touch and asking more and more questions. For me, I was looking at the slides showed that on the CT scan, and I was just wondering, because it looks very much like what we see when people present with acute subdural hematoma sometimes. So I was just wondering, although you've explained that we can look for the empty delta sign, and I was just wondering.
So Dr. Barra, go ahead.
How do you make the difference between subdural hematoma and in this?
Yes, in the interhemispheric space. In the interhemispheric space, that's what I mean.
Yeah. So clinical presentation, and also you do not rely just on the CAT scan. You have to get, in my opinion, an MRI and a venous study. If you suspect venous sinus thrombosis, you have to study the venous sinuses properly. And you can do it with a delayed sequence CTA or CTV or an MRV.
Oh, beautiful. Thank you so much.
Yeah.
And just to add to what we've just said, I think you have the delta sign with CT, non-con. We can do the CT with contrast, and you have the reverse delta sign. And of course, the MRV with contrast and contrast-enhanced MRV is the way to go. So if you're thinking anyway thrombosis, like Dr. Odes just mentioned, you need to investigate the venous outflow. Okay, I think we have, sorry, Professor Ogo, before you wrap up the day, Dr. Kuyoro, could you please come up? You have a few things to tell us.
Good Morning, Dr. Kafo, Dr. Inoa. Thank you for the excellent presentation, and good afternoon to those in Lagos or to those in Nigeria. I know we have people from all over Nigeria. I'd just like to talk to us briefly about the collaboration between WASI, that's the West African Stroke Initiative, and it was on Lagoon Hospitals. Okay, thank you, Dr. Yes. So I think this partnership just brings together WASI's specialized neurointerventional expertise and Lagoon's world-class JCI accredited healthcare infrastructure to deliver life-saving advanced stroke care in Nigeria. We'll be doing procedures like mechanical thrombectomy, aneurysm care, and all of these things usually were only accessible abroad, but will now be available in Lagos. And this will significantly reduce treatment delays and improve patient outcomes. Now, I think beyond treatment, one thing that I know that this collaboration is going to help with is really training local specialists and building capacity within the neurosurgical space in Nigeria. And this will eventually reduce our dependence on medical tourism. So I think it's a very, very big thing, and we should all latch into it. And once again, just talking about the training, Dr. Kako and his team are really big on training and developing the workforce here. And part of what they do is these grand runs that happen, regularly. And part of it is what we've just listened to today. And I'm sure you all agree with me that the knowledge transfer is incomparable and invaluable. So really, I think this collaboration is big. It's a big step in really expanding the Nigeria's healthcare system. And I'll just like everyone to, yes, be aware of it, key into it. You can refer your patients to the clinics. We have the WASI team and Lagoon's infrastructure, and bringing this together. We'll be providing world-class stroke care to Nigerians and even the West Africa region. So thank you, Dr. Okafor.
Zukuro, thank you so much for that. All right, Dr.
Yeah,
Inoa, thank you
Dr.
very much.
Uche. Sorry, I have a question. I've been raising my hand.
I'm so sorry. This is one of the
Sorry.
residents in Ireland, Dublin. So go ahead, tell us. Ask your question.
So I'm actually working on a paper right now about artificial intelligence predicting outcome for TBI. I'm just wondering, and I was in a grand round last week with Mayo Clinic in the US talking about AI in neurosurgery. Now, while you were speaking about this thing, one of the challenges, for example, for TBI is that we have a lot of heterogeneity. And while you were speaking, Dr. Violiza, right? Sorry if I pronounce your name wrongly. I can tell that apart from, correct me if I'm wrong, but apart from anatomical variations, do we have a lot of heterogeneity in VST? And if not, then don't you think what do you think about AI in this particular part of neurosurgery? And hopefully by the time I'm done with my paper, I can also share it with Dr. Uche and the group. Anyways, thank you.
That is a great question. I think well, I do not know if how we can apply AI to venous sinus thrombosis, because probably you could tell me, some of the benefits and the assets of AI for this condition. I think that the main challenge is the anatomy, from my experience and from what we have seen. Now, I know that there's some AI being generated for identification of arterial thrombosis, specifically during neurointerventional procedures. And there are softwares that are being installed in angio suites across some countries. I think the technology, or one of them, is coming from Israel. And then the plan is to identify thromboembolic events during procedures. So I know that has been developed. I'm not sure how that can be kind of applicable to the venous side, but to be honest with you, I mean, as we move forward with technology and at the rate we are, I do not doubt that something is going to come up, right? Either mapping or something like it, right? So, you know, getting information of normal venous anatomy on like thousands, if not millions of people, and then creating kind of an algorithm to identify what's missing. I think that could happen, right? So I would encourage you to continue your work, and hopefully you're going to present us back and tell us what to do.
Okay, sorry, what is the biggest challenge right now? Because from the biggest challenge, then I can look into how AI can solve that problem.
Someone that can do it, and then getting the software, right? Developing it. I don't think that exists.
Sorry, I mean biggest challenge in VST, I mean. So for example,
Identifying who will actually benefit from interventions, from further interventions. I think that's the biggest challenge. How do you know who's that patient that is going to deteriorate despite maximal medical therapy? And it could be creating an algorithm related to the current venous outflow and see how patients are compensating.
Or even just identifying the thrombosis. You see the difficulty we have. So I'm just kind of wondering where rapid can get involved in also identifying venous sinus thrombosis, although rare, but it's something to think about. All right, we'll have to, we'll have to move on. Professor Gu, please could you round us up, because I'm sure people want to get back to work.
Yeah,
Thank you
very much. Yeah, Dr. Kafo. Thank you very, very much, Dr. Inoa, for that very brilliant delivery. Before we conclude today's session, I would also like to inform all participants that next grand rounds will take place on Wednesday, June 10th, 2026. Please keep an eye out for the flyer, and we look forward to seeing you there. I will share the flyer by email on our social media channels and on our website. Feel free to invite your colleagues. If you have any ideas for topics you would like to be presented in future grand rounds, please reach out to Dr. George. Well, today's recording, as well as previous recordings of previous grand rounds, will be uploaded on the West Africa Stroke Initiative YouTube channel, the WASI YouTube channel, www.youtube.com/@wasi_official1. You could see the link to the channels in the chat. Well, thank you for joining us, and we hope this session has been valuable for you. Have a wonderful rest of the day. So thank you, one. Thank you all. See you
Thank you.
June
Thank you, guys.
10. Thank you so much. Enjoy
Bye.
the